the current microbiologist should just go one step extra to do something for the hospital. That's all I would say. Now, during this process, I have learned that post-cataract surgery, endophthalmitis is the most important infection that we deal with in our life. And the rates have gone down from 10 per 100 to now currently 1 per 10,000, 0.01%, but it is never zero. No way you can make it zero, only that percentage may change. This all has happened because of the knowledge of microbiology infections and procedures of asepsis and the development in understanding actually. Common causes, it is not the operating room air or the floor or the water, it's the patient's eye, the conjunctival flora. That's the most common cause. Any study, anywhere you read, and it's true that that is the thing closest to the wound that you are making in the eye, and it is not sterile. Conjunctival sac is not sterile, our skin is not sterile, none of our body parts except for very internal organs like heart and lungs and all other things are not sterile. So the organisms coming from the ocular flora will be the first ones to enter the wound, and if it can also happen due to instruments, unsterile fluids. Those are usually pseudomonas and fungus, but the staphylococci or colony bacteria, which are they are low virulent organisms. When they cause endophthalmitis, and they are more common causes of endophthalmitis, they are coming from actually the conjunctiva. So when we discuss about endophthalmitis, we need to know which organism is causing it, and that's why vitreous culture has to be done. Otherwise, you don't know what was causing it. This is our study long back. I have published in 1998. Again, you can see the top ones are staphylococcus. So they are the ones most common. But India as a country also sees pseudomonas and filamentous fungi, which are different from this bar we will show you. There was a bar. Well, it just shows that in the EVS study, which is from the US, 1995 published, that has staphylococcus as the most common. But ours from NV Prasad as well as from Shankar Nirvana, we have published. These two institutions have published, that's why you have the report. Everybody else is also seeing it. We have, apart from staphylococcus, we have next is fungus and gram negative. Quite high bars. Why it is compared in that graph which is missing here. So anyway, in my process of learning, I also visited many places. One place I went in Hyderabad, I was very interested in knowing how a single practitioner keeps his operating room. I am always in an institution, Aravind Eye Hospital and Hyderabad. I didn't know about the small setups. So I went and I told him I want to see your OR when I met someone in the meeting. So he took me and turned out that one OR he would keep formalin all the time. He said if I am operating for 2 hours, 22 hours there is formalin in the room. And only just before surgery, all the formalin will be removed. He would do surgery and then he would autoclave everything. He won't believe in gas sterilization or any other kind of sterilization, only autoclaving. So he said he doesn't get endophthalmitis. So that only a single practitioner can do that. An institution which is teaching and OT running from morning to evening, they can't do that. So there are all kinds of setups. So this slide is just to show you that so many types of setups are there. Some are poor, some are good, but no setup can be totally 100% claim that they don't have endophthalmitis at all. It still happens, and it's mainly because of the normal commensals in the eye. You cannot really remove them. So I'll just quote some papers. There is one by Speaker Rayal who has shown that vitreous isolates after endophthalmitis. When you take that organism and genetically you compare with what you get from conjunctiva, and it is similar in 82% of it. That's how they have proven that it comes from the conjunctiva. An EVS study also has shown that 70% of the isolates are gram positive and they are indistinguishable from the lead isolates. What happens during surgery? We are doing betadine. I'll be coming to betadine after this. We are doing betadine cleaning to remove those organisms. That's why we do that. But they come back very fast. Even in the hand, after your hands come, they again come back. That's why we have to wear gloves. You just can't prevent it. They are natural. It is their natural place. So they will come back. So they have shown. We have also published one study where 11 to 43% of cases after cataract surgery would show in the AC fluid organisms. But they are so small in number because of your removing it prior to surgery that they are unable to cause end-off in a larger number of cases. In some cases, they can succeed in doing that. And the numbers have been studied in animals, actually in rabbits, that for Staphylococcus aureus it takes up to 51 number of organisms to produce endophthalmitis in the AC, and it's around 19 if they manage to enter the vitreous. So when will they manage to enter if there is a PCR? That's why PCR is a great risk for endophthalmitis. Similarly, Pseudomonas aeruginosa, you need lesser numbers. You need 6 CFU to enter it is more. It's very virulent, it multiplies very fast, so it causes very virulent endophthalmitis. And these are the conditions you know that pre-operatively you need to rule them out before taking the case for surgery. And the reason is in these conditions the conjunctival flora increases. The number of organisms are likely to be more and maybe more virulent also in some situations. So how do we remove them? Whatever you do to remove, the first sentence is very important. Elimination is a transient event. No matter what you do, you cannot remove them completely. And so there are different ways of doing. You start cleaning from far off from the eye, your head. Everything should be clean because they will keep migrating. If there are organisms in the head, you only clean the eye, they will migrate faster. So you need to clean up as far as possible. So that means good bath, good hair, wash, head wash, all is required. Eyelashes, people used to recommend clipping it, thinking that there are organisms more if the eyelashes are big. But then studies have shown that by going close to the base of the follicles, you actually release the organisms which are hidden there. So later on studies have shown that, so it has been stopped. In Arvind, when I was there, we used to clip the eyelashes. But still we want to remove them from the operating field. So you have those special ways to remove. Adhesive drapes we are using for that. Povidone iodine is being used for the same purpose to remove these conjunctival flora. And antibiotics are used for the same purpose. You can people use oral topical subconjunctivitis, not necessary. I'll come about that little more later.
Ma'am, I had a question here if I can. Does syringing, should syringing be done in close proximity to the surgery? Close to the surgery, should syringing be avoided? And what about lid scrubs? Should they be discontinued just prior to the cataract surgery?
Syringing definitely we can't do because it brings out a very large number of organisms present inside the sac and the other one, what it is?
Lid scrubs, like for megomitis, if a patient is doing lid scrubs.
I think if megomitis is there, we have to first treat.
Definitely, but if it is resolved and patient is still continuing to do, should it be discontinued prior to taking up for cataract surgery?
I'm not sure whether there is any particular study like that to show. What do you think logically?
Again, for the same reason that you said, eyelashes should not be plugged. Maybe disturbing that thing might increase the chance
but
of.
I'm not aware of any study to answer that question.
One of our patients had pneumonitis, and when the betadine was put in the eye, accidentally, the redness disappeared and pneumonitis also improved by betadine, 5%.
I believe a lot in betadine. When I'm traveling, I carry betadine gargle with me. Whether I get sore throat or not, I do that gargle because I feel something entered while traveling and mixing with people will be taken care.
Betadine is a wonderful.
Is a wonderful.
And sometimes at the end of surgery, especially if there's a very elderly patient treated their MGD before, but on the day of surgery, sometimes they're squeezing their legs, and at the end of surgery, you sometimes find that when you remove the specular, you'll find a strand of that Begovian secretion suddenly pop out. It's so scary. You probably remove it with a bud soap and betadine or something, but that is like so scary. I mean, sometimes even if you've treated the patient for MGD for like a month before you operate, you'll still find it sometimes pop in with those some of those patients. Anything you should be doing for those, because except for just doing a small betadine cleanup at the end of surgery, nothing much.
Nothing much. So anyway, people have shown that antibiotics. We're talking now about antibiotic use free of. All of you use that? You use antibiotics in our hospital?
Orally we don't.
Not
orally
oral,
I
even
thought-
topical.
Topical, yeah.
They don't use. So the reason is there is no study conclusively proving that by giving antibiotics, end of rate is reduced. They have only surrogate markers. They have shown, there are several studies. If you put antibiotics, take a swab before and after, you will show that number of organisms have gone down. But will it result in end of reduction has not been shown. It is impossible to show. We have been wanting to do that study for a long time, but you need thousands and thousands of patients because the rate of end of is so less. So you need to do a very large study to prove that. So surrogate markers have been proven. People have shown that you give this several antibiotics. You give this antibiotic, organisms will go down. So on that basis, people are giving. But I also feel that we should give. It is not going to harm. So whether it does good, how much good it does, we don't know. It will not harm. And therefore, many antibiotics they have used. Fluoroquinolones, and fluoroquinolones, neosporin, and with time they keep on changing the antibiotics. So not one is better than the other. You go by again surrogate markers of antibiotic resistance in the lab. That doesn't translate what exactly is happening in the patient because it's being done in the lab with organisms recovered from infections, from other infections. So we can't really extrapolate that result to what's happening in the patient. So it is a question mark, but giving is no harm, and probably we should give.
So even in diabetic patients, you don't.
They
operative.
they give. High risk patients they give. Only normal, absolutely normalized. There are situations when they give. So though the literature evidence is weak, we would, it is reasonably effective, and we believe that you can give that, but it's not mandatory. Same is not the case for intracameral antibiotics. The evidence is very strong for that it helps. And those studies which I told you, they have found that, and we also found that organisms definitely enter in the AC fluid. You find it in almost 50% of cases that they are even after everything has been done. In French studies, they showed that there is tenfold reduction. But from Bhubaneswar, I did a study, I found a very minimal reduction, not tenfold reduction. That's because their end of rate itself to start with was 0.3%, which is very high in the French study. And so it came down to 0.07. For us to start itself, it was 0.1. So the reduction was not much, but there was a reduction, not that there was no reduction. And therefore, Europeans, they recommend that. And we know that in Alvinda Eye Hospital, they did very big study with the moxifloxacin. I think most of you are given moxi. It's based on their finding that more than 1 million patients, they have analyzed data and published in ophthalmology, Halipriya, that particular reference I have quoted, the 3.5-fold reduction in condition. So it's a good idea. Again, in our hospital, our surgeons are not in favor of giving for all cases. Again, we have a list of high-risk patients. We give only for them. And we leave it to the surgeon to, it's not mandatory for them. But Dr. Das designed a study to compare moxifloxacin intracameral and cefuroxime intracameral in our secondary centers. So we have around, I think we took around 14 secondary centers. 7 centers we said you give cefuroxime, and 7 centers we said you give moxifloxacin. So
Can I take a photograph?
yeah, okay. Yeah, so as it shows here, so this is also published, I have not mentioned the reference here. So in the group which were cefuroxime, before intracameral, the rate of endo was 0.05. So you see it's already very low. And the other side it was slightly more, 0.19 it was. After giving, the left side is intracameral cefuroxime has been given, and the right side is amoxi. The reduction is after intracameral it is 0.017 from 0.05, and from 1.19 it became 0.0. So both places it has actually reduced. But between the antibiotics, cefuroxime and moxi, we could not decide which one is better. Both are pretty similar. Only what I have not included here, recent data from the lab is showing resistance developing to moxifloxacin. And that we believe it's been so profusely used by everywhere, and even systemically, as well as most ophthalmologists are using it. Whether patient has conjunctivitis or patient has anything in the eye, you just go and put moxis, what is being told.
Most widely used.
Also now I think because combination of steroids and moxifloxacin
Is
are
available.
used is available, and a lot of centers taper it along with the steroids. So I think that also needs to be kind of.
So our favorite is here without any controversy is povidone. There is no controversy. It kills bacteria, fungus, viruses, everything, and no resistance has been reported developing against this particular antiseptic. It is so good, and there are landmark studies which have shown, several studies have shown it's, and it has been directly shown to reduce endophthalmitis when it has been used. And there are so many studies, E. coli gets killed in 20 seconds and things like that. So 2 drops of 0.5, but this was another study where post-op also is being given. I think orodone is now what percentage is 2.5? Less percentage, so that can be used post-op. So that also is good. Some people have reported deviating with 0.25% saline when you are doing the surgery. Everything has been used, and it definitely helps.
See, madam, what contact time do you suggest? Suppose we have put a drop of betadine and minimum contact time.
See,
Is it
studies
30
would,
seconds or 1 minute, 2 minutes?
studies would say up to 3 minutes. But if you are giving at multiple stages, that time actually passes on. We started in the pre-op area itself. So ultimately 3 minutes it gets exposed.
Then only we should watch.
Now this is a very, very important table published by Ciola et al. Taken directly from the journal, which is a meta-analysis, and it is so beautifully, it shows that all other prophylactic interventions mentioned on the left, like post-op subconjunctival antibiotics, pre-op lash trimming we discussed, saline irrigation, povidone-iodine antisepsis, pre-op topical antibiotics, irrigating solutions containing antibiotics, intraoperative heparin, all these were considered, and they gave a rating, which one is, how good each one is. And you can see that clinical recommendation, B means moderately recommended, and C is, it has no value. So you can see B is only povidone-iodine antisepsis. That also is not A, is B. And pre-operative topical antibiotic is actually C. So it remains a question mark. And similarly, the rating of the evidence, the strength of the evidence is also, 1 is not there anywhere. But 2, which is the minimum they got, is substantial evidence for COVID and not for antibiotics. Is a very important table to understand. Alright, so currently the low rate according to me is because of a combination of factors and not just using povidone iodine. It is aseptic surgical protocols of course and iodine of course. Isolation of eyelids have improved so much. Proper draping is very very important and doubtfully and use of antibiotics. This is a question asked to me very often. Should we take culture before doing surgery? No, it doesn't at all. You don't know how to interpret that. When I was in Aravind, Dr. V told me let's take culture. Later on I thought because I have less work he's giving me that job, because I did that for thousands of patients and I couldn't write a paper from that because I didn't know what sense I got from that. It doesn't help at all. You will get different kinds of organ, even staph aureus, pseudomonas, you can get in the culture. But when you have put the povidone iodine, everything is gone. So what did you achieve by doing that culture? I didn't achieve anything. When I came to Hyderabad, I told Dr. Rao I want to write a paper and do this study, which I could not write in Arvind. Dr. Satish Gupta, you may not know, but one of the very senior surgeons, his one patient got Staphylococcus aureus and the report would go to them. So he called me to the OPD. He told me, lady, you don't do cultures for my cases. I don't want to know what is growing in the culture. So it is not really useful, but you should do when there is obvious infection and you want to know what it is. Conjunctivitis is there, blepharitis is there. You want to know and then you treat and you can. Somebody called me and asked, should we take swab after treating and before doing surgery? So that after treating, the swab should be taken for you to know whether it responded or not. But if you really want to know, if clinically it has responded, it has responded. But do you really have to take a culture to know that? It's your decision. But for doing surgery, you don't have to. The eye looks clinically normal, swab is not required.
What about one-eyed patients? There was a protocol in our hospital.
How will you interpret that? If there is infection, you do. Not because it is one
There is
eye.
no routine even for
No,
one-eyed patients.
not because it is one eye. Because if there is an indication, there is a pullular discharge, something is there, you do it. But even for a one-eyed, interpretation is not available for culture.
But if we do culture with antibiotic sensitivity, so does that help in case, God forbid, the patient develops
It's not necessary that endo will be caused by that.
yeah, but
That organism for which you have the antibiotic susceptibility may not be the one which will cause that. We were completely defeated in our purpose when we were doing culture of corneoscleral rims for keratoplasty buttons. So I did, again thousands of cultures I did, but that I analyzed and we published that what you get, we were culturing, after cornea is taken, keratoplasty done, the remaining rim we were culturing. And we were finding 50% were positive for growth. Candida, aspergillus, apart from bacteria. Less of bacteria, actually fungus was more because you have antibiotics in that medium which would kill the bacteria but the fungus would grow. And there was no correlation. First of all, none of the only 5 patients out of thousands got endophthalmitis, and what grew from button was totally different than what grew from the
I think critical number of bacterial fungus that also matters.
It matters.
That matters.
And there is no way of guessing before whether it is critical.
And has any resistance been noted immediately
No,
as a result?
I haven't seen. Alright, so pre-operative prophylaxis are of no value unless you have all other things are also in good shape in the OR. Just you have everything is bad in the OR and you have done pre-operative prophylaxis, it's not going to prevent endophthalmitis. So now I am shifting to those aspects. So those aspects, you are not the only one who does that. There will be housekeeping, OR technicians, nurses, everyone is involved in that, and it's a big effort. It's a continuous effort that has to be made in the OR by a large group of people. So that makes it very difficult, because surgical infections, as I mentioned here, not only depends on the design, efficiency of the people, methods that you use, equipment that you use, but human element is the most critical. Because you can make huge protocols, paste it everywhere in the OR, but to make people follow that is the biggest task. And then you have the element of cheating, people do, they don't do, they say they have done and then they don't do it. So that kind of thing you face with the humans, which puts you in trouble actually. These are just very simple things. Anybody needs a layout and design, but remember it should be upper floors, cutter from traffic, what kind of material used for building OR rooms. And this everybody knows, you have to maintain temperature, humidity. Now ventilation, a lot of people, nowadays we are very fortunate. When I started off, we did not have consultants to do our OR air handling. I learnt everything because there was nobody to teach that. So you search for people and read in books to find out what kind of filters we should have. So whether we should have filters or not. So that's when I learned that the normal AC, which has jaggy-like filters, you take out and you wash, you have sheets clean. Those are very big. Those are the pores we need to become very small for the air to get filtered. And how small is 10 micron? You can't have suddenly, if air is going and you put 0.3 micron filters, air will not go through that, because air has so many particles, normal air. So it has to first have a 10 micron filter, then 5 micron filter, and then inside the OR, what is called HEPA filter is 0.3. And 0.3 because the size of bacteria and fungus is larger than 0.3. So they will get a filter. So we learned how to fit these HEPA filters and all that. But now we have secondary centers. So I'll show you some pictures where the kind of HEPA filter we are using in secondary centers are different than what we do in the modular ORs that nowadays people are able to make. Now why should we not use formalin? Earlier everyone was using formalin. It is a known carcinogen, and it is such a discomfort for all the staff working there. It also gives false sense of security. When the smell is coming, you feel everything is sterile, but at the cost of not cleaning, you may just go by the feeling that it has been cleaned. And people have shown studies that these controlled airs, filtered airs are as good as formalin kills organisms, there is no doubt about that, it kills. But that cleaning is as good as just having a filtered air.
Also, the formalin is required for the ventilator places.
Absolutely.
The staff will be ventilated, patient will be ventilated.
So this is how the modular OR filters would look like. This is a new OR in Hyderabad. And this is the hanging one. What you can see here, this hanging one is what we are using in secondary center. So it is 4 by 2 feet thing just on the head, and it has HEPA filter. So it takes air from inside the room, filters, and it just keeps going down. So we have fixed these in secondary centers.
We have a similar one, I think, but with the cost.
Okay. Maybe design is changing, this probably is the old one.
Box like small filters, HEPA filters, are they effective?
They are HEPA?
They say
No, you have to find out whether they are HEPA. I don't know.
What about normal AC, ma'am? Normal AC in operation theatre?
No, those filters, they are 20 mic, the holes are very big.
So ideally it should not be used. So.
No. Ideally, AC is required, and
I know.
split AC is better than the window AC. People have, I think Ravi Thomas has published from the window AC fungus, and if the fungus is there in the box, in the filter, and air is coming and patient is here, it will be throwing fungus directly on the operating.
But even with split AC also, the
And
dash
it
is
must be cleaned every week. We recommend every week you must take out the mesh, wash it, and then and preferably wash with some antiseptic water.
And how the laminar flows with the plein air unit and with the AHU, how frequently should the filters be cleaned? Because as you said, there are 3 levels of filters. Like the 10 micron and there's the smaller
So
ones.
the 10 micron and 5 micron are outside the wall. They are cleaned once a week by the maintenance people because they are detachable, just like the AC, it just comes out. So they can clean it, wash it and put it. That's cleaned more often because that's when you have more of dust. FR filter you cannot wash.
You have to replace.
It has to be replaced. So what we do is you have to monitor. So how do you monitor? I'll come to that, as well as there is something called particle count. So there are machines, these people who fix it, they have that. They collect the air and they count how many particles are there and they give a report, acceptable or class 1, class 2, they give you that. They will suggest whether you need to change your air filter. We do our own checking, which I'll come to. This is just to show that mask and cap is always, no matter, I've taken some pictures like even in the area where washing is being done, where everywhere mask and cap should be there. We don't want any staff to remove mask and cap anywhere. And people coming from outside, like for example, I took a picture of this fellow is coming to fix a computer there. So they also have to change, they also have to follow up the protocols.
I read the American Journal of Ophthalmology long back that these masks, which are ordinarily worn in the hospital, silver masks, they are not effective in controlling bacteria.
Maybe. Yeah, I have also read them. They criticize because when they do the study, they do find that some bacteria is escaping from that, but still it is better than escaping directly.
There are masks of different types. The study is called maskology.
Three-ply mask is what
Yeah,
in
we
COVID time.
learned a lot during
During
COVID.
COVID.
COVID has taught us so many things. So if you can afford to do that, our doctors, we give them that COVID, N95 we did give them, they wear that. They won't be close to the patient, but other stuff, we don't know how much it works or not, but definitely it's better than just talking openly. Okay, there's one point in this, everybody knows how to do at the nurses. You should watch when the nurses are doing it. We have had cases where even the old nurses, they become very complacent. They don't do it properly. So the doctors have to be very vigilant. When post-op infection happens, then only you realize that I should have washed or I should have slept. And one point Ravi Thomas told us, I don't know how important that is, that these swabs, when you are taking it, it should go from lateral to medial. Because medial part of the eye has more of organisms in the medial canthus. So you take it out like that rather than smearing it back into the eye. So this may be important. So in our video we have tried to show that. That was a point I didn't know before until I heard from him. Alright, scrubbing again. Now how we do it, I'll be coming to surveillance. We have a team of 2 nurses who go around the ward every day. Because we have 14 wards, so one day they go to 2 wards, then they go every day to the ward. They have a checklist, and in that this comes, how the surgical scrub is being done. So they'll be standing a little far and watching how the nurses are scrubbing, fellows are scrubbing, because there are too many trainees we have. So scrubbing procedure can't be taken for granted that everyone is doing it. And what is used is normally betadine 7.5%. In one place in second year, why have I written not Bactolin? Bactolin is given by the company Raman and Wheel. Sometimes they come and teach you, you can use this for scrub, So they had done that in one of our secondary centers. When we went on a round, we saw this Bactolin. It's just a liquid soap. They were using because Raman and Wheel told. We don't have to learn from them. So we should not use.
What is the water source? I can see some purifier.
Yeah, we have RO plant on the terrace, and in addition we have this aquaguard.
And this is a UV basically, UV plus filter but not in a UV. Because RO, the flow of fluid cannot come so fast.
No, RO is on the terrace.
Madam, what about the UV lights in the operation theatres?
Yeah, it's good to have. It's good to have.
We again,
I think some of them, it comes with a modular or
Yeah.
also they give you it.
So
Right?
there are practices that some of the OTs, they while going out, I mean last case, they on the switch on the
Not when the patient is there
No,
or
no, no.
people are there.
While the OT is finished and everybody is going out, they on it, first thing they close it and then enter.
Yeah, that's good.
it's a territorial.
Causes lot of,
Right. People should not be there.
also now it causes lot of discoloration and damage in equipment.
It does,
Because
it
over
does.
time, we used to have it in our LASIK OT for about 10 years.
Yeah.
And it used to discolor everything.
Everything, yeah.
Then we started switching it
You
on.
can
only an hour
minimize the
before.
use. It's good, but you have to determine how much to use it. Only one thing is it's a straight light, so it will only sterilize the surface. It doesn't go anywhere down.
Can soap be used like something like you're recommending that only detergent? We are using detergent only. But like before we used to use soap,
No.
especially not the bar of the soap, but liquid soap.
That is before, first scrub, you can initially just a gross cleaning you can do with that, but not as a scrub, it's just a cleaning. Alright, this, all of you do this, we insist on this in spite of the scrubbing. They come back and they wipe it dry and then put sterilium and let the sterilium also. Then, yeah. This we had introduced just few years back.
And isn't that scary? Like when you have somebody using the elbow to press the pump. I've seen in some work that we have traveled to do a lot of life surgery. I've seen in some places where people would scrub and when they do it with the elbow and your hand is under it and you see one drop,
The water.
I know. And it's not encouraging. Somehow I feel that a
But
foot
that's why you have to
operated.
wipe before.
I understand, but somebody who bypasses
Yeah,
this
yeah.
can be so.
Yeah,
I was
yeah.
thinking we should encourage foot operated kind of a thing rather than the elbow operated thing.
Again, we have to watch them. Gloving, we have to teach them also no touch. The part of the glove should never be touched with even a scrubbed hand. We should not consider because we have scrubbed the hand is anyway sterile, it is not sterile. These are all no-nos, everyone knows. Okay. This is variable in different ORs, but we follow this that before the first patient, anyway, you have to clean them. After each patient, we clean the floor and dustbins and everything is clean. Some people argue with me that why should we do after every patient? But very minimal is coming out, especially from cataract surgery. So they would like to do after 3 patients, 5 days. No, we don't know how to recommend that, but we believe that we should do after every patient. So it's up to you actually how often you want to do it. And of course, closed cabinets you don't have to clean every day, but once a week or once a month. And OR table also has to be cleaned after every patient. The entire table you don't have to use, only once a day at the end of the day. Instrument stands again after every patient. What do you use for cleaning the OR?
125.
One
We
time.
recently
You
shifted
were
to-
using bacillocin.
Yeah,
right?
ma'am, we recently shifted to
B125. This is a good one, no smell, doesn't have a strong smell, and it's friendly with hand, and even tables and equipment, it doesn't leave a stain or something. Bacillocin had all those problems, so it's taken care. It's a good one. Sodium hypochlorite, that's not a sterile.
For surface cleaning, yes.
For surface cleaning, yes, but in what we have done in the OR, we keep D125 for everything. Because the housekeeping gets very confused. If you say this one for this and this one is for that, this percentage for that, they just cannot remember. And they have different staff coming different times. So we have just D125 for the OR everywhere, for everything.
For cleaning floor.
For everything. But in the OPD you can change it. Then these are just general things like sweeping should not be done, only wet mopping. And the mop should always be beside the wash, should not go out. Should be washed and dried also. Like we do at home, it has to be dried so that organisms don't grow. So, on the same care. Okay, this is important if you have a stores inside the OR. they bring in the cardboard boxes, all your material comes in, you should not bring the box inside the water. So we make sure that at the gate itself, box is kept, and things are lifted and brought, or you have plastic trays in which you transfer and then bring into the water. These cardboard boxes have mites in them, small mites and insects, dust comes from that. So these cardboard boxes should never come inside the water, even into the stores. We give a round of the stores and we check that there is no cardboard box. And then scrub areas, special cleaning, you must check that they are clean and they are kept dry after the war is over tonight. We use these two for instrument cleaning. Instru Plus is an enzyme which will remove biological particles, and aseptic for cleaning 1%. So, but what is important is 2 changes of distilled water in the end. So after you have the instruments cleaned with Instru Plus and aseptic, which is Savlon, it should be removed with the distilled water. That part they sometimes they just do in the tap water and they put it. The distilled water is important, but tap water, it is an RO water. Even then there can be something which will settle on that. So
It causes corrosion of the
corrosion of the instrument at the hinges and then this point was made. Dr. Subhadra recently, she was very mad in the HICC meeting and nurses were not doing. So some of the tubular bore-like instruments, they should be cleaned immediately by the nurses after the surgery, not wait for it to go to the cleaning area. By then it will dry inside. So it must be cleaned at the table after the surgery and then sent for. Sterilization is a job of the technicians, but they should also be trained. And it is important that they learn about the autoclave, proper packing. What's important is labeling the packs. It should have, I've given a list here, date, when it has been packed, name of the package. You can name, you give names to your, if you have cataract 10 sets, cataract 1, 2, 3, 4, oculoplasty 1, 2, 3, 4, like that, some name you give. That name should be written in the register. And that, against that name, which are the instruments inside that should be written. Load number, in a day so many times autoclave is being used, and the person, so that you can ask him if something goes wrong. And date is important for expiry. So what is your expiry date? Your autoclave today, and if you don't use it tomorrow, day after, how long you can keep it? So we earlier had 48 hours, but we found it very difficult. Then I read up again what to do, how long we should keep it. There is no particular guideline how long you can keep it. It depends on the kind of cloth that you are using. And how do you determine the quality of the cloth? By the thread count. Then I learned what is this thread count. So 140 thread count means within some area, I don't know how much area, there should be 140 thread this way and 140 thread the other way, horizontal and vertical in particular area. So the quality of the cloth matters. So we don't know what is, when we ask the shop fellow, what is the count of your cloth, they don't know. So we also don't know. So we decided, and it says that if the count is 140, the material can be so good that you will keep for 1 year. People have tested and kept for 1 year and then tested and found it's correct. So, but we didn't want to take a risk. Anyway, we have a high turnover. So we made it from 48 hours to 1 week. So if something has not been used within 1 week, you re-autoclave and use that. And for plastic, which is gas sterilization, we do 1 month. So date has to be written. And reject any fluid has to be checked. I learned from Arvind Eye Hospital. They made a box with half of the box, I don't have the picture here. Half of the box is painted black, other half is white. And there's a place to keep a bottle in front and there's a tube like this. So you put that light, if the bottle has fluid, has any particle, it will show. And in both black and white area you should see, because some particles may be white, they will be seen in the black side. The particles which are black will be seen in the white side. Very beautiful box they are made in Arun. I got the prototype from them and we manufactured that. So you have to check every bottle that you are using for particles before using.
Can we autoclave this river cake and normal saline bottles?
If it is in glass.
If it is in glass. Some
But
companies
now
claim,
it is all coming in plastic.
some companies claim that even if you autoclave our plastic bottles, they don't like it and they get out. IOPR people are clear.
It may melt. We were autoclaving when it was bottled. Glass bottle. Alright. Biological indicators everyone is aware of. So that is a live bacteria which is beautifully, it comes inside these are this tube. This is the original one. It will be purple fluid inside. So the way it is, you can see that the purple fluid is in a glass ampule actually, very thin glass ampule, which is inside a plastic tube. And there is a filter paper between these two layers, which has bacteria. And the type of bacteria it is, it will die only at 121 degrees centigrade for 15 minutes or 134 degrees centigrade for 3 minutes, which are the two autoclave, high speed and low speed. So the bacteria, whether it is dead or not, we have to autoclave it along with the other things. And you just press it, crush. The purple is a fluid culture medium. It is so nice that you don't need a microbiology lab for this. So you just press that, the fluid will come out and touch the paper. And then if bacteria is present alive, it will grow and it will become yellow in the incubator. And they are supplying incubator, just below that is the incubator, they supply that also. So you don't need a lab for this. In your oval you can do. And it will become yellow if the bacteria were alive, that means it has failed. Autoclaving has failed. If it remains purple, autoclave is good.
How frequently it should be done? Biological
That's a big question, it's quite expensive. So NABH, we have to fight with NABH about this. They said every load. So we are doing it first load every day. Earlier we were doing once in 15 days, once a month, some people do that, that won't help actually because large number of packs we are doing. So first load we do every day.
Now suppose it's a smaller setup and the cases are not like, suppose you have OT only twice a week and every OT you just do about 2-3 cases. Then in that case, how often do you need?
It's all just economics. Scientifically, if you say we have to do it every day. So we will only talk about the science because autoclave can go wrong even the second time that you are used. So there is no way, there is no this averaging is only for your economic reasons.
How expensive is it?
40 rupees.
40 rupees?
140 rupees.
One
It's not very costly, but if you do it every load, if you do it, it will be costly. Every load. So we are doing once, first load. And then here you are seeing something with several lines. I'll tell you what NABH has been telling us. This is called Bowie Dick. It is actually, this is the way the pack is. So I should have taken a picture. So there are, this pack is this thick. It has a wad of papers here and papers here. This card is in between that. So, and it's a pack. You autoclave this. So what it is testing, the penetration of the steam through the wad of paper to this card. And the card has these lines. So if steam touches these lines, it is originally yellow in color as the center one is showing. And center one is partially changed, so it is not effective. Steam has not gone and touched all parts of the pack. The other one, completely black, it is very beautifully steam has entered. So it is basically testing the penetration of the steam. So NABH now requires that every pack you should do, every load you should do this. But that also we have decided to do. This is more expensive, it's 500 rupees each one. So now I don't know. When I was writing and making these slides, that time it was 500 rupees. So it might be more now, and now we are doing every day first floor. And they want in all our secondary centers also. We do. Our secondary centers are now going for NABH. So in Madhol we have already got NABH for secondary centers. Slowly we will be going for each one. Tertiary centers are all NABH. Those who have gas sterilizers, you have to, the biological indicator is different. It is just a different type of material in that. The organism is, but principle is same. It's Bacillus subtilis, and it requires incubation at 37 degrees. So it doesn't require a special incubator. 37 is all incubators are 37. Whereas the other one required. Plasma sterilizer, those who have, again it has a biological indicator. Storage is very important, where you keep your sterile items. These are some of the guidelines for that. So I'm sure Dehradun is having this pollution board regulations for, so you have to follow that. Do you have closed dustbins or open dustbins? Recently we had this problem, that's why I'm asking. We had all open ones.
Now the recommendation is for the closure.
Yeah, but we are finding it very difficult. Because we don't get good quality. Suddenly that food, it doesn't work. It doesn't work. So you have to use your hand. You can't soil your hand for opening the dustbin covers. So we are facing problems. So we have this time decided to have open ones. Let NABH come next time. We'll talk to them and argue with them and decide. It's very tough.
That fruit operated ones,
But
They don't open. They break. They don't
and then
open.
the amount of air that rushes out from them while you close the lid,
Yeah,
that is also
Yes.
dangerous.
And people are lazy. They put it on the top of the lid.
Yeah.
Because it is worse.
also the amount of disposable that we generate now is so much that these the foot operated ones, you don't get very big ones. You only get the
Very
smaller
good,
ones.
very small
They
ones.
fill up in no
Fill up
time.
so quickly.
That's another problem we
It's a
face
big
because we
problem,
started
yeah.
using foot operated for certain things. But some of the bins had lesser things and some had lots of
The
like,
good quality ones are very
they're very
expensive.
expensive.
And plastic ones don't work.
And what about steam, like those indicators like the class 5 and class 6 indicators?
Yeah, I had that. Yeah.
Because there's another thing where also the
See, we use
tube,
a-
the PC, what do you call it? That tube which has thing at the end of it for basically, that's another thing we use for sterilization.
NABH
But PCD,
requires type 5.
PCD, process control device. Yeah.
PCD.
PCD tubes,
A small tube, and in the end of it there is this indicator.
indicator. Because
So
you know, we are
the
using
steam
lots of
passes through
tubes.
those tubes,
Yeah,
and
good
then
to
it
use
goes
that.
penetration, it shows.
It shows. Yeah, you should
We
use
use
that.
that once a day for our rooms as well,
You should use
in
it.
addition to these.
In addition to this type 5 and TST.
And we do use the Covidic antibiotic as well.
Yeah.
But for class
So
5,
what's
class 6, there is a
important-
lot of confusion which is better, so I wanted to understand.
No, they are all good.
Because between the two, how do you decide?
3M is the company which makes good quality.
We are using
3M.
3M and
But at times there is
there's a huge
non-availability
shortage
of
of indicators right now. We are not getting indicators, we have to struggle to actually get. We used to use vapor line also, so what we were doing was we were using vapor line is class 5 and with a 3M which is class 6. So we put about 4 or 5 of the class 5 and 4 or 5 of the class 6 in each load. And of course it works out very expensive, but then we were using both and we did some tests with many of these indicators and you interrupt the cycle at various stages. And we found that most of them don't meet
The
criteria.
requirement.
Only one or two of them
half
pass.
of the cycles, the indicator will turn black. You have seen that. That is not correct. At least you should.
The labels I think I already mentioned, the labeling is very important. Then we move to surveillance. None of these will happen unless we are having constant methods for surveillance. So what we have CCTVs, every OR, and 2 CCTVs, one to cover the room and one to cover the operating area. 2 are in there. And after much much thinking we have done that. It's a lot of expense actually. And the other thing is, 2 nurses, I told you there's a checklist, they go around, they check all those protocols that I mentioned. So basically the idea is to improve the awareness, it does, because then they know that people are watching, the performance is different. And then overall discipline definitely improves in the
In the wash area also we can have CCTV.
should
That
have
we
as
see.
many, yeah, we should. Coming to microbiological surveillance, I'm sure everywhere it is being done. But if you read books, even very good books, it says routine microbiological surveillance is not required. But it is required when there is initiation of a new OR before you start. Then when you are renovating the OR, some work has happened. AC is installed, painting is done. And when there is an outbreak of post-op infections. And then for legal purposes in India, we need this. Whenever their patient goes to consumer court, the court is going to ask whether you are doing this or not. However, routinely it is not recommended because it's as good as something we should insist on cleaning rather than testing whether it should be cleaned. There is no testing whether it should be cleaned. It has to be clean. So we should put our resources and our mind to monitoring how the cleaning is being done rather than testing. So that's the argument actually. It's not required. But that's why there is no guideline, because it's not required. There is no guideline. So what we have made ourselves is do once a month. I don't know how often we do, and how often it should be done, nobody knows, because there is no
What is
guideline.
the best time of taking culture?
Early morning. It's all cleaned in the evening after war. So
But
early
then
morning
why-
before you start war.
I feel while the working is going on, that time if you take it will be more conclusive.
No, you are testing your efficacy of your cleaning.
Okay.
You are testing that. You are not testing during while work is going on. No, what's happening? It will definitely be contaminated.
How many cultures were required?
I'm coming to that. So this is my own decision. It's not given in any book, and now of course we have only written in the AIOS guidelines and other Vision 2020 guidelines and all that. It doesn't come from any book source because books say that is not required. So what we have decided, just logically operation table to take from that, microscope handle because you are touching there, instrument trolley which should be really sterile. And I have included AC duct, which I am questioned, why do you want that? Duct is what the outlets for the AC. So I feel if we don't do that, they will not clean that area. If you say that I am taking a swab from there, they will definitely clean. And in that process, the whole area gets clean and they spray something. So it's just that thought, it's not scientific action. Autoclaves, though we already discussed, and water for scrub. We test the water.
And there was sampling from the floor.
Floor.
And also the air sampling.
Air, that I'm coming to, but floor we don't know. Floor, walls, I don't believe in. Picture has gone.
Maybe we can minimize.
Yeah, sure.
Also the players. In the ones
No, it's not showing otherwise.
It's not compatible with the.
Yeah. Okay, so this is the kind of report we give from the lab for all these items that I mentioned to you. So we just say whether there is growth or no growth. And this is maintained in the OR and in the lab also. NABH looks at all these. Then a few words I'll speak to you about what happens when there is an outbreak, which is defined as an unusual or unexpected numbers, increase in number of hospital-acquired infections. Nosocomial infection is the same name for hospital-acquired infection. And in our case, we are interested in surgical site infection as well as enterocolitis. So our protocol is actually very strict for this, and and this I'm mentioning, some names are mentioned because I teach in the hospital. So first thing is the primary surgeon is the one who will see the post-op and realize immediately, must send an email to a large number of people, which starts from chairman to people who are in charge there, to microbiologists and quality control people. Because it's an institute, there are so many people involved in that. And then we have form 2 and form 3, which they're supposed to fill up, which basically is collect all the information and fill up that form and refer the patient to retina service. And this picture I have shown here, there is a kit, I'm sure you must be aware, from Mono Lab. They have all the things required for giving intraocular injections. So we keep this in all our secondary centers. And the administrators are immediately asked to give reports about the autoclave and then trace which autoclaves were used, which are the items used for that patient. All that tracing will be done by the administrators, and a format is there for them to enter the results. And as quickly as possible, endophthalmitis meeting will be held. Within 48 hours, you have all this information. And the surgeon will have to report every day. And the retina surgeon now has to report what's happening, and meeting will be organized. So what you discuss in that, total, the surgeon will be told first to explain. Even if it is secondary centers, on Zoom they have to first describe their case, and then we will look at all the reports that have come. So all documentation should be available for tracing anything that we want. And then look for something common which might have happened. With all brains put together, we discuss what could have happened. You hypothesize about that cause, and then try to culture whatever is hypothetically you think this might have happened, and collect and look at the CCTV footages to find anything during surgery, any complications during surgery, and then submit all the reports and let people discuss. So what you realize during investigation is documentation was very important, and that's when we go to the OR and we find this is not written, that is not written, then you correct those things. So whether you find the cause or not, you at least find the loopholes at that time, and you come to know about that and you correct that. So I always say that if documentation is not there, you just cannot do any investigation. So how do we find what went wrong? Is usually check all the methods that they have used, check the autoclave records, gloving techniques, certain items which might have led to. From LVP we have, long back we have published the phaco machine tubing giving problem. We had 8 cases of LVP in one, and that was Dr. Sangwan. He published that. So that was such a big experience for all of us. So I was in the OR for almost 18 hours searching for things and trying to, and he was with me to tell me that this could have happened, that could happen. We finally found it was the phaco, because we got the same pseudomonas, we got the same organism, but genetically it was same. So you need to get involved immediately. If there is a delay, you will not find the items which were suspected, which could have caused the endophthalmitis. And many things get corrected during this process. These records in the OR as well in the laboratory are very important. In the CSSD, we should have all these, we discuss about that indicators. They all have to be stuck in the register as a proof, which LVPH also wants to see that you have proof of every autoclaving that you have done, every sterilization that you have done, and you have note of which patient has got which pack and which instrument was used for that patient. The tracing has to be there. Now I have highlighted here temperature in the register. These are the columns in the register. This we added recently because technicians sometimes don't understand, and it's our fault we don't explain properly. When we talk, we need to know the intelligence level of that person to understand. So we should talk that way. So what they were doing, they had in time and out time. In time is switching on, out time is switching off. They were not seeing anything else, so they were writing that time. Then I said, what was the temperature at that time? He said, we don't know. We don't know where to look for temperature in that machine. So then we had to look at that. I had to show them that the in time is for that temperature when it comes, which is 121 degrees centigrade when it showed that is in time. And you have to keep it for at least 15 minutes and then you write your out time. And if it is 134 degrees when that temperature comes, because machine temperature will go slowly, it will reach 134 after some time. If the switching time is here, but temperature has come here. So if you want to write this time, you write, but this time also you have to write. Double you must write, otherwise you write only the temperature time. So they need to understand. And there was this question came because the indicators were not changing color. We looked at the indicators, they were not the dark blue that they should be, they were brown. Why is it not working? Then we looked at temperature was not reaching the temperature. And in secondary centers we have those horizontal autoclaves but not very good company autoclaves, you know.
So here I wanted to ask you about B class versus S class. I mean, which like they now recommend B class, but is S class
Vacuum, you mean? What does it mean?
and
Vacuum.
S class will also do a drying cycle. I mean,
Dry
B
cycle.
class will do a drying cycle.
Dry cycle.
S class will not do a drying cycle. It will have vacuum to remove, I think,
Dust.
air, but it will not have a drying cycle, so it won't come out dry. So that's probably the difference.
Yeah,
And,
the quality of
we
the
have
autoclave.
upgraded our autoclaves now to on B class. We still have an S class, which we currently use only for some things which are not intraocular surgeries basically. But that was one question, and the second was that now of course all the new autoclaves they have printouts come out with every moment of the cycle, and we stick those into our
You must
systems.
keep that.
So that helps because then the staff cannot fool you.
They cannot cheat you.
Yes, yes. So that was. And then the third question which I wanted to ask you in between, but maybe if I can ask you now. I personally feel that modular routines are hiding a lot of things behind the walls, and it is very scary.
I believe, I also feel that.
I discussed with Dr. Hari.
Because you are not cleaning that what's
I know.
behind.
So I'm always very scared about what's going on because modular routines were made like few years back, and
So many
you can't
insects can enter and hide behind.
Once upon a time in our routine, like few years back, we found a lizard moving along the planar unit, and it had found its way there. And obviously it can't be clean and we can't get there. And God knows what else goes. So why do we insist on modular routines? And what's the science behind it? I feel, so I visited in Chennai, the new one, and I visited with Dr. Hari all the 18 OTs that they've made. They have not done modular even one. And we discussed and we realized that we were thinking on the same line. So what they've done is they have only all the walls are like impervious, but in the four corners they put ducts which can be cleaned. So they've got the airflow units and the plein air, but they don't have modular, and I'm totally against modular routine. Actually, it is the worst thing that has happened to us. Maybe in a big institution and with anybody you can take this up.
Yeah, I saw a video. It was very, very disturbing. That's why I'm telling you that. Children, we give tiffin boxes. They have a rubber kind of a ring which you don't take out every time to clean. So that video was showing that you remove that, and there are so many. They're very hard to remove. Once you remove, you can't put it back, kind of. They're meant for sealing the heat, but they hide the insects inside. So it is similar kind of a thing, something which is hiding.
Madam, can you at your level be suggested to the government that these water OTs are not working so that NABH people don't trouble?
It's not just not trouble, but we should come out with alternative guidelines of what is permissible and what is better. Because I think it's not as if
Epoxy
we are
painting. Epoxy
we
painting
did that
is
in our
what
basic
is.
OTs and all, and it works well, but I feel that maybe even impervious kind of big tiles or something might still work. I think they did that at others.
Here they used to have just granite or
because anything that you can't clean is not going to remain clean. And in modular routines you cannot clean that gap which is just 2 inches or something. You will not reach there ever. Unless you demolish
something
it.
dies behind that, you will never
Yes,
be able to.
so you must take a fight against the modular routine. And when I traveled in the US, I have not found them using modular
I
routines.
think we have to talk to the companies which are doing this.
Ma'am, but they all want you to do modular because they make 30-40 lakhs out of each modular routine. We have to talk with scientific data to the government and to NABH that they should stop
We have to do
insisting.
the job of taking it out and seeing behind, taking pictures.
doing a study on modular OT, what is behind the scenes.
Some people's ORs you can take out, take pictures and show that there are dirt in it.
There are now endoscopic cameras which can go behind the walls and that can, some kind of a study can be done.
This kind of a study should be done by many people at many centers.
I agree with that. That thought has come to me also.
अदरवाइज जिंदगी खतरे में पड़ जाएगी. लाखों और करोड़ों रुपए का जब नुकसान होगा ना किसी कंपनी का, they can do anything.
Much of our work is driven by business.
This is just more of documentation. In the EMR also nowadays we are using EMR, so we need to enter a lot of new fields in that, which will keep all the irrigation fluid expiry date, manufacturing date, all processes that we are using. Everything should be entered so that we have data collection. So this is my last slide, that all surveillance activities should be put in place as much as possible, and we should welcome that. We may or may not find the source of an infection when it happens, but you will at least review your protocols and find loopholes and correct them and prevent further post-operative infections. With this, I thank you for your
Questions and comments?
And what about footwear? That's what kind of footwear is best? And what
which
about foot
doesn't
hygiene?
shed, it doesn't shed any fibers.
For patients and for doctors. I mean, foot hygiene. How do we look after foot hygiene?
Food hygiene.
I mean, when somebody walks in, like patients, what kind of footwear should they have, and what kind of footwear should the staff use, and how should we ensure that it's not bringing in? Because I noticed that sometimes there will be possibility
I
of
think patients, so you cannot monitor what they had before, how they have their food hygiene, we just have no control on that. So we need to just cover it. So you have those foot shoe.
What about the patient clothing?
We change completely.
All
We change
patients.
completely.
The problem with footwear is when sometimes when we see a lot of diabetic patients with diabetic foot and all.
Yeah.
It's very difficult to take them
That's
to the
very-
operate, even for a single
Those
intervention.
are special cases.
Yes, and their smiles and all, and they really require some treatment, but it's very difficult to take them because of the
That's a very sad thing that your
significant
patients.
gangrines in their foot.
So usually all patients are changed.
We change in all our hospitals.
One day accessories also patients are supposed to remove them and come to the OT, or
What?
the accessories the patients are wearing.
Accessory meaning jewelry.
Yeah, most of them they have
They
one or-
should, yeah. Their relatives will be there, they should handle that. All the instruction you should give beforehand.
One day
We are
prior.
giving set of instructions, in that you say that remove all your jewelry.
We are
As
talking,
we say to take bath, wash your hair.
we are talking about patient, but what about doctors? Some doctors, they also, they are
They should remove, actually I had in my slide that they should, jewelry, no doubt that they have to remove it. The question was about mehendi. Question,
Nail polish,
in
nail
our you have HICC, I hope that committee should be there, which I just showed there, that you have to have HICC committee which will actually discuss these things and implement these things. So in that we discussed was mehendi. So one of the nurses, she was having mehendi, and then she started arguing, and the doctor also joined in arguing, who didn't want to let the nurse go. That this is something which is in the dermis, epidermis, it's deep and it's not coming out. We said, yeah, that's true, but then as we don't want anything, we can't have, we need a discipline, and we don't want people to have something visibly there.
what about nail polish?
We should not do that.
Same thing is true for tattoos also. I mean,
Tattoo-
immediately after
tattoo also,
tattooing.
some tattoos they come out, isn't it? They
Yeah.
should not.
What about mascara? Because that can we have because that by giving intravitreal injections, anti-VEGF injections also. A lot
The
of people.
doctor should be knowing it.
Yes. No, but sometimes
Mascara
patients.
can just drop like
Yeah,
that.
but
No,
some
it's
patients.
a question about patients having mascara.
Yeah.
We have a
They
problem.
should do it. They are supposed to.
I'm talking about the patients.
No, they should not have.
Now the kind of cataract surgery is less, so do you recommend to wash wash after every cataract case, or can we just wait for few cases and then wash again?
Everything, we do everything.
Every case.
Scrubbing we do. In Aravind, they just take out gloves and change them.
We also do that, but
At your own risk, you do that.
What
We
about-
don't teach that.
What about phaco packs, like on the machines, there are these very expensive packs which you cannot change them after every case. You know, the tubings and the sets which come with all the expensive phaco machines now. So while you can change the phaco handpiece, you can change the tip and sleeve.
I think handpiece they change.
You have to, but then the phaco pack is basically, you know,
But I think the machine people, when I talk to them, there's never any backflow from that.
and we
That's
do
very
use reflux
foolproof.
sometimes.
Foolproof.
We do use reflux sometimes very
Reflux.
seriously, right? So, I mean, technically,
So the risk is there.
there is that risk. But,
I think the current machines have become better with no backflow at all. Is what I
usually
thought.
no.
What I heard about
Technically, it
it.
will be, I mean, you know, you're using the same pack. the
Because
same-
when
same
it
piece
happened
of
with
cotton.
Sangwan's cases, there was a back.
That was
internal-
reusable tubing, right?
Internal
Now
tubing
it's
was
disposable,
contaminated.
but,
We found the organism in the internal tube.
Ma'am, the person who is collecting the culture, should he scrub and then PP and then enter and then collect the sample? Or because
See, when
different
that
labs
person
they
is
have
coming in
different.
the OR,
yeah.
that person is coming in the OR, you completely have to change. Just like coming in the OR, everybody has to, that's what I meant by
No,
saying,
no.
anyone
Using
enters
gloves,
that.
scrubbing and all. that is-
Scrubbing not required, they just put gloves.
Okay.
But changing is required, mask, cap is required.
That
PP is there, but some people they don't even use.
They
the
just put gloves.
What about the air culture? Air culture slides.
I think that's the picture which went off, was it not there? Okay, we do air sampling. Two pictures had gone off, maybe it was that. So, I think there was a slide where how to collect these things was there. So, we use blood agar and it is called settle plate method. There are two methods. Settle plate is what we do, air sampling, one machine is there. So that machine, I think High Media or some company is having that. I used that but I didn't like it. So that machine will actually, there is a strip of media in a round wheel-like thing. And then you expose it to the air, it will drag air, some cubic feet air, and it will implant the air on the medium in a circular manner. And then you take out the strip and you incubate and look for colonies. So I found excessive contamination in that. Because that's an open strip exposed like that, and then we are dragging air, so we don't know whether it is real, you know. So I like to use my own medium, so blood agar and Sabolot agar, 85 mm plates. So plate has a lid. So on the operation table, we go and we open the plate and keep the lid next to it, slightly hung on the edge of it, and expose for half an hour, and then close it, then bring it and incubate. Then blood agar is incubated for 48 hours, Sabolot agar for 4 days, because fungus grows slowly. And then we count the number of colonies. So that slide showed that 10 colonies or less is acceptable. More than 10 shows heavy contamination. So in that case, we will give a report that not acceptable. So they have to again clean the water.
What about
Fungus
fogging?
zero. No fungus.
Fogging of modular.
Fogging, if you are having HEPA filters, no fogging.
Otherwise, normal.
Otherwise, every day, end of the day.
Is there any use of air purifier or something?
Air purifier.
Where there is no HEPA filter?
I don't know. That thing scientifically they don't explain how it really purifies. What kind of a filter is there, how much it drags air, how big the room it can purify, I have no idea. It's totally commercial, that product. People during COVID also they started using it in their house and all that. And I think patients who have pulmonary problems, they use it at home.
And can we use 70% alcohol for the cleaning of surfaces, like putting table?
Yes, yes. In the lab also we use 70%.
How long do you retain
But
disposables?
we are using D125 for everything.
Like after the OP finishes, we are supposed to retain some of these disposables that we use for 24 to 48 hours, 48 hours I think. So, so that just in case there is an incident, you will be able to kind of test out.
We don't do.
We don't do that because that was
How much can so many cases how can
Yes,
So
what
I
is
have
this?
heard that Sudha Sutaria, I remember in one of the endocrinologist meetings I went to Pune.
It was
She
there
was
in the
saying she
guidelines.
keeps it for 1 week. For 2 patients, if you operate, you can keep, but large number of patients,
It
how
was
will
there in
you?
one of the
She used to
guidelines.
keep everything used for patients. It is impossible.
Another problem is we are using lot many plastics and everything is comes in a cover. We are not able to check each and every packet whether there is a small hole in that packet.
We found cockroach in a gloves, sterile gloves. We wrote to the company. AIOS had sent out a note also about that company. It was a leg of a cockroach or something like that in a glove, sterile gloves. That company name we informed AIOS and they have surveyed.
And what is the scrub
That,
time?
that speaks of our quality control in these places.
And what is the scrubbing time you recommend for the surgeon?
Duration. I think first scrub is 3 minutes and next to next day if you have not gone out 1 minute.
Can dehumidifier be a source of infection?
Can be, but I don't have any proof written somewhere. Can be.
Better than bloody.
You often have a problem of fogging out in
Humidity goes up.
because we significantly face that
People
microscopic.
were using H2O2.
Yeah.
You remember it was called Envidol or Envidil something from not Sun Pharma, it was some Gujarat, some company was there. So it would produce so much water. H2O2 will break into H2O and O2 and everything would become moist. It is a good disinfectant, it kills, but you can't live with that moisture everywhere.
Sometimes microscopes will go bad.
Everywhere.
And if you do not have a modular OT with the HU and everything, what is the technique for fogging? Like what material, what do you suggest for in case somebody wants to fog? Because a lot of people don't have a modular OT.
Yeah, same D125 we use sometimes because whenever in the
For cleaning or for fogging? I mean,
fogging also you can use it. The same thing you can use for
is it okay for microscopes and like microscopes? Does it tend to penetrate them?
but we prefer that you cover it.
Cover.
Or do you cover them or do you remove them from
Cover.
the?
No, not removing. Removing is not
Because
good
then-
for the machine and
Machine,
enjoy
thanks.
removing. This was a discussion actually. Machine gets bad if you keep on removing.
What is the time and the volume for that D125?
That will be written on the bottle.
That is
I don't remember.
Do you have a separate protocol for washing instruments if you use it in an infected case versus a sterile? Same.
Only thing is you have to decontaminate before the sterile cases it will go directly for washing, but this one you have to decontaminate, so twice you have to do. Decontaminate first, soak it in the aseptic for some time and then you
10 minutes.
Same goes for surface antigen positive and HIV cases.
same. First you have to decontaminate, you don't want people to touch it. It is a big what should I say, for HIV the hue and cry is unnecessarily too big that you should you should not should wear double gloves or you wear double gowns and all kinds of things, that all the things should be separately kept. Nothing like that. HIV, first of all, patient is having HIV. How much of HIV is coming, and virus is very, very fragile. It's it just the moment it dries, it will be killed. And you are totally protected. You have to protect. Universal precautions are enough. And many patients will be unknown. You don't know whether they are HIV positive, HbSAg. HbSAg is almost 10% in the population. Lot of people will be positive. So you have to consider every patient is infected and take that precaution, not only thinking or or knowing that this patient is HIV, even unknown patients you should think they have HIV. So take that universal precaution always.
And what is
Never touch blood with bare hands.
the ideal solution for decontamination is?
Sodium hypochlorite is enough, which is a normal disease. Viruses are very, very fragile.
LBP to test viral markers like for patients or undergoing surgery like that?
No, we were not testing them. I was testing before. NABH told us not to test. I was involved in that. So they said you are not authorized to test unless you have a reason. Patient comes to you, you can't do the test without telling the patient and for what reason you are doing it. So it's unethical and not acceptable to NACO actually. So they said you can't. So we stopped it and we taught everyone, all surgeons, anesthetists, we informed them that we are not supposed to test. But these oculoplasty people, they said so much of blood we face because of the surgeries are bloody, and they said we would like to. So now only for oculoplasty patients that our physician will write, and we have to. So NABH was convinced by saying that we are having requisition from the physician to do the test, and we have physician as a counselor. That's a requirement of NACO. If you do HIV testing, there should be a counselor available, and the report is confidential. You should not reveal it. So all those you have to show that you are doing that, and our physician is the counselor. So we do only for oculoplasty.
Sometimes when we operate HIV positive patients and of course you're following the same precaution.
Universal precaution.
Only thing we change is that we, even though I don't know if it's of theoretical interest, we post them as the last patient for that session.
You can do that.
We do all that. Sometimes, while operating HIV positive, you suddenly realize our hepatitis B positive, that the PSS is flowing from the eye and then it flips onto you. Of course, it doesn't penetrate skin.
It doesn't penetrate unbroken skin, it will never go.
Right, but it kind of is little things,
The concern is more here and real.
But hepatitis B is more common as compared to the.
Yeah, much
we have seen a
more
lot of cases of
very
hepatitis B
common.
positive.
It's very common. We had a drive of testing it before giving vaccine. We were testing for antibodies of hepatitis B. In our lab, we have hardly 25 people, 2 were positive. So what percentage is that? In the hospital, so many people. Hepatitis B is very, very common. So we must consider everybody's blood as infected.
A small question that when we use BPD and then let's say for intravitreal injections, anti-VEGF injections, then after that we usually irrigate with saline, and then while we are marking that this is 3.5 where we are injecting, the caliper is also
On the conjunctiva.
on the conch. The caliper is also usually dipped in BPD and it leaves a mark, like the BPD.
Oh, the color comes there.
Yeah. So next day I've noticed that if we don't copiously irrigate, then patient does have foreign body sensation for that day. But by washing, are we taking away the beneficial effect of BPD?
3 minutes time.
Now, if we have sufficient contact time, and then we kind of irrigate it. But again, we are marking with a caliper and.
I'm not aware of, I've not seen somebody giving that. You give the injection and on that point you are putting the
So you
needle.
mark the area where you are injecting
With
with
the
a caliper, which is dipped in betadine
and
because
then you inject in that place. The
we don't wash again.
the marking is for that
Marking it,
injection.
the marking
For the injection. How much time anyway passes between this method that you're doing?
The marking and the injecting, not much.
You are washing after giving the injection.
After that, we again put antibiotic drops because the second time when we are marking, there is a minimal BPD, there is hardly any BPD.
But is there any difference in rate of infection?
Not really. It is just for the marking part. No, it's not really.
In the US and UK now nurses are giving, even in Singapore I was visiting
They're giving the OPD.
the nurses in the OPD, they're giving all the
operation too, which is maintained like one.
In the US also it was in the OPD.
Yeah, they may give, but their countries
Different.
their patients are different countries.
And maybe the spores and whatever.
Yeah,
The
everything is
environment
less. Their
is very,
environment is
very
less.
clean.
When you find dust in their country, your shoes will be so clean, no matter how much you have
Ma'am,
walked.
coming to that, where I trained for my fellowship, they used to enter the OR with shoes,
With the
they just
just
put
the
the
shoes.
covers over it.
Actually, the shoes doesn't have anything. Everywhere it is tiled and everywhere it is so clean. That's different. We can't
So
copy
it was
that.
shocking initially, but then that's how they do it.
We can't copy that. When Dr. Rao came from the US and he started the hospital, he used to go to the canteen and all that in the OR dress. I stopped.
When the US also
Really,
wears
when I joined, I said, you can't do that. You are doing it, everybody is doing that.
in the US where they visited where Sharma was doing his fellowship, it was UCI and
They would
UCI.
go with the
They come from home in their OT
in
scrubs.
the OT and they go
They
straight
park
in
it in the parking, then they walk it all day there, and then when they go back after 12 hours, they're still in the same scrubs. So they don't come to the hospital and change. They come in the scrubs from home. And they were all in the shoes, in the LASIK OT, in the retina OT, they were all inside with their shoes on. I had a shock.
We had during COVID, our doctors started wearing scrub suits in the hospital. And so there was a question whether when they go to the ward, whether they should change to another ward. We said, you have to change. The same as in COVID time, they started wearing them. Our country is not same there. The weather is not same. It's sweating. In the car also, if you come, you get covered with dust. It's not same.
So keeping into mind the unsafe environment we have in this country, doctor when enters the OT, should he or she not take bath?
There was this protocol somewhere.
Germany.
No, in India.
I
there
think
was-
Shankar
Shankar
Netra,
Netra,
Badrinath used to insist on washing your feet.
Yes.
It happened with me when
Huh?
what
You have
happened
to
on
wash
the-
your feet, all nurses, doctors, everybody has to
On the
wash.
day of OT, ma'am, I happened to see an infected case before OT by mistake. I was told to go back
Go
to
take
the
bath and
hospital,
come, yeah.
take a bath and come back. I had to do that.
But he was very strict with the.
We had similar culture in Ganpati Yatrala Jalna. If you do a DCR,
Go
into an infected
have
OT,
bath and
you
come.
go have
The
bath and
Shankar
come back to
Netra,
the
people were working there.
Yeah, Jalna is basically a based
Jalna
on-
is basically,
Yeah.
only one or two were LGT, but most were not related.
You have separate OTs for infected cases and for all OTs are, if you, if a patient underwent a vitrectomy for an endoscopitis and after that.
They normally do it in the end, but no separate. I read somewhere, hospital infection, there is a nice American book. It has a chapter on minor OT concept. It says it should not be there because you compromise everything in that minor, so-called minor OT. And the very beautiful sentence was, you have no right to give another infection to an already infected condition. Patient has infection, let's say with streptococcus pneumoniae because of DC, dacryocystitis, and you are doing DCR in a minor, you are giving pseudomonas on top. You have no right to do that, like compromising the methods. And I saw it firsthand. I feel bad to say what I saw in Arvind. My friend was an ophthalmologist. She was going to do DCR. I said, I want to see DCR. So, minor routine. I'll tell you from the beginning. At the door, chappals were kept inside. She kept her chappal inside. So I also kept my chappal inside. Then went to the OR table. She only wore a mask. Sari, same sari. No change, no cap. She wore a mask. So I also wore a mask. She washed her hands with Lifebuoy soap. It was there. Lifebuoy soap. And she said, this is minor OT. Patient is given the DCR surgery. I'm seeing so bloody. So much is cut. This is removed. It is totally invasive surgery. Anything can enter, isn't it? It's so invasive it is. And I just didn't like anything. And when I read this book, I could correlate very well with what was happening. And then instruments were all, they used to be those days a sterilizer, one rectangular box, electrically, I think it was immersion heater inside and boiling. It was a boiling thing, sterilize and all the equipment for this.
This happened to me, I was visiting for
And you are cutting so much and exposing the tissues.
the president of the American Society, I'm forgetting his name, he passed away.
Steiner.
Roger Steiner.
Steiner.
So I was seeing patients with him in the OPD and then we decided, he said, okay, now we're going to do CCTV. So I followed him and we just walked into a corridor, just like a hotel corridor, and then suddenly this door opens and he walks inside, and when I look inside, I see one intralace and one excimer. So, and I walked in with his shoes and I stopped outside and I wouldn't walk in because I was wearing shoes and I knew it's a lazy routine. And then I was trying to figure out what to do. So I took off my shoes outside, but I saw nobody else had taken off shoes. But anyway, I took off my shoes and there was no mask and there was no cap. And we just walked in. And then I just stood in the corner. I was kind of very scared of what was going on and I was wondering what was going to happen. He did the interlace, he did scrub. He did scrub. And the nurse who was assisting him did scrub. And then he went to the examiner which was next to it and then he just took some small
But did he put some sterilium or something?
No, nothing. It was so scary for me, but then I think, but it was a very clean hospital.
How do
so
they get away because of using all the sterile?
Before the examiner, he did, I mean, take some
So,
discipline.
but how do they get away with
That means there is something wrong with all these theories. Scientific theory.
But when it comes to war, better be overdoing rather than underdoing. It doesn't matter if you are overdoing.
Somebody has rightly said that cleanliness is next to godliness.
Well, that's true.
But then, ma'am, there's a green movement now, so this year's ACRS lecture by David Chen was on this concept, that he was trying to talk about the urban system and how they have been able to cut costs because we've gone overboard with using disposables for everything. So his whole lecture was on how much carbon and how much nature we are destroying by.
I heard
There's
that.
that article also.
Yeah,
It's
but it was a
correct,
20-minute, it was a award-winning lecture. He was giving
It's a
all of
very
those
article
names.
also in ophthalmology
It was a
or
named lecture which he gave.
That's it.
yeah, on the same topic.
I think it was a Kelvin lecture.
So that's how they recommend even two OTs in this, two tables in the same, it
He
reduces.
spoke about everything,
It reduces.
and he spoke about evidence-based how we can, emulate that in the US, because in the US it's a very big cost, and the industry is against it. So
Industry will be against.
it's on the website. Yes, it is. But I think we've had
But
enough
we
to-
keep going in circles, when we were using steel plates in the canteen in Hyderabad, I remember initially we had steel glasses, steel plates. It won't be washed properly. It used to be, something is sticking and all that. Then suddenly we decided we should go for disposal. Then we started seeing our dustbin filled up with those. Then again we went back. So it keeps going, unless you develop a good washing system for those steel vessels. So everything has its own problems.
खाने की बात तो ये है कि वो जो साउथ वाला सिस्टम है पत्थर वाला
पत्थर
वो बेस्ट है
हाँ केले का
केले का पत्थर बेस्ट है
आजकल वो इस पत्तल बनाते उसमें एक प्लास्टिक का लेयर डाल रहे हैं दैट इज आल्सो बैड only पत्ता should be there no they put a plastic cover that is not correct केला पत्ता is best साउथ में अभी भी है I live in Bangalore for every function even you go to somebody's house if there are large number of people they will actually bring केले का
It's very good for you to keep it with that.
they wash it and in any case kela growing somewhere is not going to be contaminated with some disease causing organism at the most some small insects maybe
So with that, I thank ma'am for patiently answering all our queries, and I would request Dr. Banna and Dr. Gagan to please give her a small token on our behalf.
how many things you want to give we already gave that I hope you got something
would request Dr. Gandhi sir and Dr. Gaurav to please hand over a moment.
अभी बाकी है.
This is your institute.
Yes. I invite all of you to please join us for dinner. And dinner will be at the restaurant, the rooftop restaurant. Please join us for dinner.